Good evening to our esteemed faculty and everyone on board. As a French writer said, it is better to debate a question without settling it than to settle a question without debating it. As so many options are available for each condition these days, debates and discussion are need of the hour. And it's my proud privilege and honor to invite our expert for both the debates, Dr. Ranjana Khanna Madam, Founder President of Prayagraj Chapter of ISUPARK 21 to 23. Madam is National Vice President FOXI 2017. She's at present, she is ICOG Governing Council Member 21 and 23. With immense pleasure, I invite our judge for the first session, Dr. Amrita Jaipuriyar. She is obstetrician and gynecologist at Jaipuriyar Medical and Research Center and Garg Hospital. At present, Madam is President Gorakhpur Obs and Gynae Society 21 to 23, Secretary of Gorakhpur Menopause Society and Secretary ISUPARK Gorakhpur Chapter. We welcome you, ma'am. Topic of first debate is the better choice progesterone in recurrent pregnancy loss, DYDROGESTERONE versus natural micronized progesterone. And today's debaters are Dr. Parul Gupta Khanna and Dr. Monica Ambadan. Dr. Parul Gupta Khanna is OBGYN and infertility consultant at Kailash Hospital, Khurja. She is communicator of ISUPARK Prayagraj 2011 to 2013, 2021 and 23. She is also ex-assistant professor of DY Patil Medical College, Navi Mumbai. And now about our second debater is Dr. Monica Ambadan. She is consultant obstetrician and gynecologist at Mangalya Nursing Home and Atharva Fertility Center. She is also youth coordinator of EMOX 2020 to 22. She was also website coordinator for EMOX from 18 to 20. We welcome our judge and both the debaters. And I request all the debaters to stick to the time. Each debater will get 8 minutes to put his views.
A very good evening to all of you. I would be speaking on the topic DYDROGESTERONE, why it is the better choice progesterone in RPL. RPL is defined by RCOG and ESHRE as 3 or more consecutive pregnancy losses, whereas ASRM defines it as 2 or more pregnancy losses. RPL may result from large range of etiologies, yet in almost 1/3 of the cases, no cause is identified and are classified as unexplained RPL. These patients are then empirically treated using progesterone supplementation or other immunomodulatory drugs. Now, what are the issues in progesterone use for RPL? First, whether to give progesterone or not. Then if yes, what formulation, by what route, and what is the safety profile of the drugs available? Now, if we look at the literature, PROMISE trial was one of the biggest trials conducted by Dr. Kumaraswamy in UK. It was a randomized double-blinded RCT, and in that he assessed the role of oral micronized progesterone in recurrent pregnancy loss. Now, opposing to the name, the results were not very promising and came as a shock to us because the study concluded that there is questionable benefit of oral NMP in recurrent miscarriages. This is another literature which this study was conducted by Dr. Ashok Kumar. It is also a double-blinded RCT, but he assessed the role of oral DYDROGESTERONE in early pregnancy to prevent recurrent miscarriages. And the study concluded that DYDROGESTERONE has a significant role and it reduced the risk of recurrent miscarriages significantly. Not only that, there was also improved gestational age and baby weight at delivery. There are various formulations available in the market like 17-hydroxyprogesterone, oral DYDROGESTERONE, and MNP, which can be used in pregnancy, out of which DYDROGESTERONE and micronized progesterone are used commonly. Coming to DYDROGESTERONE, what makes it so special? Now, DYDROGESTERONE is a retroprogesterone. If we look in this diagram, we can see the DYDROGESTERONE has a bent structure opposed to the linear structure of progesterone. This is because of the shift of methyl group from the beta chain to the alpha chain. Now, this unique structure accounts for DYDROGESTERONE's high selectivity for progesterone receptors and no androgenic glucocorticoid or estrogenic activity is seen. Also, the structure results in enhanced oral bioavailability, which is 5 to 6 times greater than that of micronized progesterone. The dosage required is 20 times lower than that of micronized progesterone, that in the range of 10 to 20 milligram. And specificity to the progesterone receptors minimizes the side effects and likelihood of altered liver function. In contrast, if we see this chart, micronized progesterone has relatively high agonistic activity at androgen receptors as well, adding to the side effects. Oral micronized progesterone, despite the micronization to reduce the size of the drug, the bioavailability is very poor with values less than 5%. Poor bioavailability warrants the use of high doses in the range of 200 to 400 milligrams. And high doses leads to increased risk of side effects like intrahepatic cholestasis, drowsiness to marked sleepiness, which our patients routinely complain of. Now, if we compare the various routes of progesterone, injectable route has highest serum progesterone levels. But adverse effects like injection site pain, risk of abscess formation, and inflammatory reactions makes this route very less favorable. The vaginal route gives us the highest endometrial progesterone levels, but untoward effects like discharge, vaginal irritation, and bleeding causes decreased tolerability and compliance in the patients. Oral route is the easiest and most acceptable for the patients and is preferred over the other two. Now, if we look at the pharmacokinetics, oral dydrogesterone is rapidly absorbed and quickly achieves peak plasma concentrations compared to the vaginal and intramuscular route in only around 0.5 to 2 hours. We have also documented evidence for immunomodulatory properties of dydrogesterone. It reduces cytotoxicity of natural killer cells, increases progesterone-induced blocking factor production, and shifts the dominance from Th1 to helper 2 cells, which is conducive for the success of pregnancy. Now let's compare the metabolites of the two preparations. High concentration of circulating metabolites and reduced pregnenolones are seen with micronized progesterone. This adversely affects the pregnancy outcome. Also, it has been seen that the metabolites lower the implantation rate per embryo with oral micronized progesterone. So far, we do not have any documented evidence available for the immunomodulatory effects of progesterone metabolites. Now, the metabolite of dydrogesterone is DHD, which also has immunomodulatory properties like the original molecule. It shifts the cytokine balance from Th1 to Th2 and also induces nitric oxide synthesis, which improves endometrial receptivity and pregnancy outcome. Dydrogesterone in RPL. This was a study by Karp et al., where 2 RCTs and 1 non-randomized controlled trial was studied, and a significant reduction of 29% in the odds for miscarriage when dydrogesterone was compared to standard care. So they also found that dydrogesterone was very effective in reducing the miscarriages. This is one of the latest studies published in January 2021, where the role of dydrogesterone was assessed in ART cycle for luteal phase support. And it was found that when dydrogesterone was given from 6 to 20 weeks of gestation, it significantly reduced the incidence of preeclampsia in high-risk patients. Lotus 1 and 2 trials have also led to recent approval of oral dydrogesterone for luteal phase support. The author also found that when pregnancy rate at 12 weeks of gestation was compared between dydrogesterone and micronized vaginal group, the pregnancy rate was higher with dydrogesterone. This is an Indian study where dydrogesterone was compared with micronized vaginal progesterone for assessment of subendometrial blood flow parameters. And the study concluded that dydrogesterone was more effective in improving all the Doppler indices, including PI, RI, PSV, and S/D ratio. Now, when we compare dydrogesterone with the sustained release preparations, dydrogesterone has high bioavailability, hence low doses are required. Also, being specific for the progesterone receptors, there are less side effects. And the metabolite, that is DHD, also is responsible for the success of pregnancy. We have also evidence which states that high serum progesterone levels are achieved with dydrogesterone in a dose of 20 milligram when compared with oral NMP sustained release preparations in dose of 200 milligrams. This is another study by Dr. Amit Patki, wherein he assessed the role of dydrogesterone in ART cycles. And they concluded that pregnancy rate was significantly higher with dydrogesterone than with progesterone. What are our guidelines saying? Global guideline recommendations favor dydrogesterone in RPL. The European Progesterone Club guidelines recommend that dydrogesterone leads to reduction in the rate of miscarriage. FOXY position statement on use of progesterones, it recommends dydrogesterone 10 milligram twice a day till 20 weeks of pregnancy. ESHRE guidelines on RPL state that vaginal progesterone during early pregnancy has no beneficial effect. However, when oral dydrogesterone is initiated after fetal heart rate has been confirmed, may be effective. To conclude, I would say that dydrogesterone does not suppress the pituitary gonadal axis at normal therapeutic doses. It prevents the inconvenience and discomfort related to intravaginal or intramuscular progesterone applications. Being an oral route, it is patient-friendly and improves the compliance to treatment. Enhanced bioavailability and selectivity for progesterone receptors minimizes the side effects. We also have documented evidence of its immunomodulatory properties. The only disadvantage being the inhibitory cost. But considering the mental agony and anguish couples with RPL go through and role of dydrogesterone in such couples, cost factor can be ignored. Thank you.
Dr. Monica, to start your presentation.
Very good evening to all the faculty and the senior esteemed members. At the onset, I would first thank the organizing team of Prayagraj, Dr. Ranjana Khanna, Dr. Amita Tripathi, Dr. Aruna and Dr. Chitra Pandey for inviting me for this webinar. I would also like to thank Dr. Amrita for chairing this session as a judge. Actually, my opponent, Dr. Parul Khanna, has elaborated on lots of studies on the use of progesterones. I would not like to go into the details of the studies, but I would definitely like to enlighten the aspects of use of natural micronized progesterones and why it is important in our country. There are various other modalities where progesterone is available as natural progesterone. For natural micronized progesterone, decreasing the particle size increases the absorption and bioavailability of the progesterone. Both dihydroprogesterone and the natural micronized progesterone are actually derived from a plant source called as diasgenin, which is from Dysphoria villosa. Both of these progesterones actually have the similar metabolic activities when they are taken orally. It has a half-life of 5 to 10 minutes and is mainly metabolized in the liver to pregnenolone, and progesterone is mostly bound to albumin. So when we are taking oral progesterone, it is mostly rapidly absorbed and the entire dose is expected to be metabolized in the first pass metabolism in the gut and the liver. Since this taking of the oral progesterone will reduce the bioavailability, the entire money that the patient is spending on buying a oral progesterone is going waste. Hence, a vaginal route or an injectable route is definitely preferred for an exogenous progesterone. Most of these are available either in doses of 200, 300 or 400. These to completely protect the endometrium, we need a progesterone dose of at least 300 milligrams, which would be given in divided doses either orally or vaginally. If the patient is educated and she knows how to insert the tablet vaginally, then vaginal natural micronized progesterone will definitely be of help. we generally do not advise sustained release capsule formulations, but sustained release formulations also have certain which have been made. They are monolith dissolution control delivery systems. Hence, the first pass metabolism is a little slower as compared to dehydrogesterone. Most of these progesterones are lipid friendly. The progesterone is used in luteal phase defect, in recurrent pregnancy loss, in preterm labors, multiple pregnancies, and pregnancies in ART. Ideally, when we are giving the progesterone, what we are achieving is uterine quiescence, because most of them in the first trimester or in the second trimester cause complaint of pain in abdomen, and maintaining uterine quiescence will continue the pregnancy longer, increasing the receptors and increasing the vascularity also, and hence improving the blood circulation to the fetus. The relaxation of the myometrium is because progesterone inhibits connexin 43 gap junction protein, and estrogen increases the connexin 14. They block the action of oxytocin, and hence the uterine contractions are reduced, and they alter the progesterone estrogen ratio. What is the rationale of using progesterone in the first trimester or second trimester losses? Is maintaining uterine quiescence, because mechanism of labor is progesterone withdrawal, sequestration, and disruption of the membranes, which will increase prostaglandins and oxytocin release. Hence, progesterone will definitely help in maintaining the uterine quiescence. The list of studies, my dear friend, Dr. Parul has elaborated, are endless. She has also quoted the PROMISE trial, the LOTUS trial, and the LOTUS 2 trials. All of them advocate progesterone, but when we go to other studies, most of them say that the vaginal progesterone gives rise to a higher circulating levels of progesterone, where actually it is required, and not the oral progesterones, that is both micronized as well as dehydrogesterone when taken orally, also give rise to a lot of other symptoms, including GI irritability, nausea, vomiting, constipation. Constipation at times is very severe, and patients are in a lot of discomfort. Those patients who are on ART treatment ideally are taking progesterone. They are also taking injectable human chorionic gonadotropin injections, as well as the injection hydroxychloroquine. The progesterone amount that has been given as luteal phase support in the IVF patients is so much that they are complaining of constipation too much. That is why vaginal route to cross over the first pass metabolism and to reduce the systemic side effects would be definitely of a better use. The list of studies for dehydrogesterone versus progesterone are endless, but in a country where socioeconomic status is not much, cost effectiveness is the key. Better compliance with sustained release options, because progesterone needs to be given in a divided dose. The post-treatment blood progesterone levels more than 14 micrograms have been noted with natural micronized progesterones rather than the other counterparts of it. And use of natural micronized progesterone vaginally reduces all the side effects of the oral progesterone. Thank you so much. Over to you, ma'am.
Thank you, Dr. Monica. And now I would request our judge, Dr. Amrita Jaipuriar, to give her opinion and judgment.
Thank you, Dr. Chitra. Thank you, Dr. Ranjana and Dr. Amita, for giving me the opportunity. So well done, Dr. Parul and Dr. Monica. Points well taken. Both of you were efficient to prove your points and show the studies. But in my opinion, treatment should be individualized. Both of you were convincing, but of course, the problems with the oral are definitely there: nausea, vomiting, drowsiness. And with the vaginal progesterone, definitely if the patient is bleeding, the drug can get washed off. So we should not forget this psychiatric problem. A patient can be suffering with a psychiatric problem, the kidney disease, renal diseases, and there are so many cardiac problems. So we get a lot of variety of patients where we need to individualize, where we need to give a vaginal preparation, and where do we can switch over to an oral preparation. Cochrane 2019 studies have proved that whatever route we take, whatever preparations we give, progesterones are very effective in preventing the pregnancy losses, especially the early pregnancy losses. So both of you, I congratulate you all for the presentation. And this is my opinion. Over to expert Dr. Ranjana.
Actually, I've heard both the talks. And one thing I wanted to point out was that with the natural micronized progesterones, we do need a very high dosage. And that high dosage sometimes can be inhibitory in the sense that often patients complain of sleepiness, drowsiness throughout the day, if it's taken in the daytime. So of course, it is advocated to be taken at night. So we can overcome that problem by giving it vaginally. But then if you see the PRISM trial, which was done, in which they said that 400 milligrams of vaginal tablets were inserted twice a day. And then also they found no significant advantage in the live birth rates. So that again comes to the point that maybe we need something which is more effective. So I feel I've had a very, very good actually response with dydrogesterone. So maybe I'm a bit biased, though the cost is inhibitory, I'll agree. But then you compare it in recurrent pregnancy loss where the patient has lost the baby 4 or 5 times. And it's quite expensive to lose a child also, because it entails abortions or, loss of health, loss of money, loss of blood. So everything is there. So dydrogesterone has some advantages, especially it increases the PIBF and it causes increased production of TH2 cytokines. And they are the ones which actually help to carry the pregnancy forwards. Plus, it has no adverse effects on the blood pressure, the weight, the clotting factors, the lipoprotein, whereas this has not been told, but NMP does increase the HDL. So it has an effect on that, but this does not have. Adrenal and renal functions are also unaffected. And in threatened abortion, I agree. If it's the first time that the patient is bleeding, then what is advantageous is, though inhibitory cost, again, I would say, but if you give 4 tablets at 40 milligram loading dose of dydrogesterone, and then, 10 milligrams BD, that would be fine. I agree the cost of giving NMP is much less. Sustained release preparations are there. So for maintaining, after 5 months, NMP would be good. Or if it is a case of simple threatened abortion, maybe we could just, and the patient's pockets do not allow, maybe we could go to the oral NMP drugs or vaginally. But vaginal problems is there in India, especially. People are very, very hesitant. They will say the problem is of bleeding or aap andar hi goliyan rakhwa rahe ho. Especially the, elders in the family will mind that. Though it is very good because the hepatic bypass is there and directly it gets absorbed from the vagina only. So I think as Amrita has said, that we have to individualize the cases. See, take everything in toto into consideration. What is the pocket of the patient? Can she afford? Because if she can't afford dydrogesterone, then maybe she breaks the treatment only and ultimately ends up not taking any progesterone. So as we all know that the effects of progesterone are really good in maintaining pregnancy. So I would reiterate that DYDROGESTERONE is the better choice. Definitely the better choice because of the immunomodulatory effects also which are there. Though progesterone is also said to have, but I have seen very good results in RPL with DYDROGESTERONE. That's my opinion.